Hello and welcome to Dementia Unplugged. I'm Jeannine Forrest, and I am very glad that you're able to join me and the Dementia Society of America in talking about this topic of comfort considerations in the late and final stages of dementia. When we talk about comfort, I hope by the end of our time, you'll understand it's more than just the absence of pain. But comfort is a much more expansive concept when we talk about not only the physical, but the emotional and the spiritual side of improving remaining quality of life in the late and final stages. So I come to you with a long experience of working with people with dementia, but also in the hospice and palliative care world. And it has been a very fortunate blend to be able to use these skills. So I will move on and let you know that in general, the way this format works is that I provide about a 30-minute presentation and then open it for questions and answers for the last 15 minutes. So before we get started, I want to share with you this important message.
Welcome. Please listen to this important message from the Dementia Society of America. All content, including any potential medical information, is provided as an informational resource only and is not to be used or relied on for any diagnostic or treatment process. It should not be used as a substitute for professional diagnosis, care, and treatment. Please consult your healthcare provider before making any healthcare decisions or for guidance about a specific medical condition. The opinions expressed and the content shared by Dr. Forrest are not necessarily the opinions and content of the Dementia Society of America. Thank you.
Before we get sort of delve into this topic, I like to usually start out by making sure we're thinking about dementia in the same manner. So the word dementia is really an umbrella term, much like the word cancer, where there's many different types of cancers, lung, breast, prostate. There are at least, we now know, close to 100 different types of dementias, with Alzheimer's, vascular disease, Lewy body, frontal temporal being the top four. And as we talk about comfort in the late and final stages, all of these concepts may be applied to any of the different dementias. So some of these topics can be generalized. Unfortunately, in our current state of science, the dementias from Alzheimer's, frontal temporal, Lewy body, and many, many more, they're terminal from the start. And that's important to know that. So as we move forward, we're going to talk about what comfort means, especially as we move towards the end of life. I like to start with this quote by Hippocrates, who's often coined the father of medicine. We can cure sometimes, we treat often, but comfort always. So if you're ever told that there's nothing more we can do, that line really applies to sort of the curative piece. But there's always something we can do to make someone comfortable until they take their last breath. So what does late stage dementia look like? It has the similar characteristics. The person will have profound memory deficits. There may be an inability to recognize close family members. Not always. You may have moments where what I like to say, there's sort of like a loose light bulb. Sometimes the neural connections connect, and you'll have moments of clarity. But in general, there may be difficulty in recognizing, remembering close family members. The person will have minimal verbal abilities. In addition, the individual will need assistance with eating, dressing, grooming, toileting, and walking. These are considered our activities of daily living. And more often than not, there will be bladder and bowel incontinence. So this person really requires a lot of hands-on care from their family and or professional caregivers. I like to say at this stage, it's very, very difficult for most family members to do this alone. It does require almost a 24-hour plus type of recognition and patience and physical care. Now, we can look at all of our sort of comfort and treatment decisions through a lens or a funnel called goals of care. And this has to do with any advanced illness, but we can look at, is the goal to prolong life, to maintain function, or is the goal to provide comfort? Well, since, again, our state of science doesn't allow, we can't cure any of these dementias, comfort is typically the most appropriate goal of care. And maintaining function whenever possible. And so that's the lens that I'll walk you through as we move from the late to final stages. Another word for comfort is palliative care. Palliative care is a specialty in the areas of healthcare, and the whole focus is to relieve suffering and improve the quality of life, sometimes with other appropriate treatments for persons with advanced illness and their families. So we talk about symptom management, not the cure of the disease, but maintaining comfort through symptom management. And symptoms include things like pain, anxiety, shortness of breath, could be constipation, diarrhea, severe itching. So it's a specialty in which the symptoms can be better relieved. And in that mode, we can improve the remaining quality of remaining life. In the advanced stages, there are very common problems that can be anticipated in people with dementia. And two common are eating difficulties and infections. So the brain controls not only cognitive functioning, but motor functioning. And motor means muscle activity. So eventually, people lose the ability to walk, the ability to control bowel and bladder, and ultimately the ability to swallow. And one needs the ability to swallow in order to eat and chew well. But what happens, and this is why most people die, is that they inhale their own secretions their own saliva or food, and they aspirate and they develop a pneumonia. But as we move towards that progression, people will need assistance with feeding because they may not be able to bring the food to their mouth with a fork or a spoon. Eventually, people will need help with reminders or cueing or prompting to chew and to swallow. Sometimes people lose the ability to remember how to chew and swallow and will pocket that food. And so this creates this sort of domino effect where food sort of stays in the back of the mouth and pharynx, and person will cough, they'll inhale the food and fluid into their lungs. The other common problem is infection. Because person isn't walking as often, they become more bedbound over time. There's a tendency for the urine to stay in the bladder, and the bladder doesn't empty as quickly. And so the bacteria collects, and so there's bladder infections. Ultimately, the person, again, is sleeping more, or the food is collecting in the lungs, and a pneumonia develops. And some people develop what we call a septicemia or a blood infection, and that can occur from a variety of ports, but sometimes it's from the bladder to the kidney infection, and ultimately it moves towards the blood. So when we talk about comfort, we have to think about what comfort means for the person with dementia. And that should always be sort of at the top when we're looking at ways of caring for someone or making those treatment decisions. Because usually by late and final stages, the person needs the power of attorney for healthcare to advocate for those wishes. And if that power of attorney has not been identified, sometimes substituted judgment has to be made on behalf of the person with dementia. But if you're a person listening and you're a caregiver who needs to make those decisions, imagine your loved one standing at the end of the bed looking on. What would he or she tell you? What would they want? That often lessens that sense of burden that many family members feel, that weight of making decisions on behalf of what does comfort really mean for someone with late and final stages. Listen to prior conversations, listen to their values, listen to the way they've talked to you in the past. That'll help you identify ways to comfort them. So going back to feeding, I want to get more granular. And what does that mean? So first of all, we have to make sure that the mouth, the oral cavity is somewhat intact, that there aren't any lesions or sores. That can sometimes cause difficulty in swallowing and chewing. When one no longer is able to feed themselves, you can look at the option of finger foods, cutting small sandwiches, small pieces of cheese, something that the person can still feed themselves with dignity. We also use adaptive equipment, sort of a weighted spoon or a dish or a plate that has a guard, so when they manipulate food on the plate, it doesn't spill over. You'll see that texture of food can be varied. So in the beginning, person may eat a sort of a regular meal, and then it may be moved and modified to softer foods. Towards the late and final stages, people often eat what we call a pureed texture, and it's highly blended. I would also encourage that people eat high calorie foods, because this is a time when individuals may be losing weight because of the difficulty eating. And so this is a time that people enjoy quite often very soft and sweet foods. As you see in this picture, or if you're listening, there's a woman assisting another, perhaps her mom, with hand feeding. This takes time and patience, and to be able to do this safely, allow the person enough time to swallow. And lastly, as the person really does lose the ability to swallow, I'd like you to consider pleasure feeding. Pleasure is just, I should even say pleasure tasting. So instead of just tasting, oral care, meaning toothpaste or mouthwash, when they're no longer eating or drinking, just little drops of perhaps a chocolate or lemonade, or even a Merlot, what would bring them pleasure? As people move towards the late and final stages, this is a time to talk to your healthcare provider, but in my experience, it helps not to have any dietary restrictions. So a low salt, low sodium, low cholesterol diet no longer cuts it. Look at the remaining quality of life. What would give them pleasure? And so it may be a delicious, high calorie chocolate milkshake. That's much better than giving Ensure or Boost or something like that, which has a tendency to cause some gas and some diarrhea and cramping. So look at high calorie foods versus getting sort of protein supplements that are artificial. Comfort foods. Yes, chocolate pudding, macaroni and cheese, soft and sweet. They're high calorie, they taste good, and there's a connection there, especially if a person has a special favorite comfort food. Offer them this meal frequently. I also like to say that appearance matters, especially if the person is eating pureed food. On the left, you have sort of lumps of different types of food. Perhaps it could be a pureed chicken and some unidentified green, maybe broccoli and potatoes or carrots. But if the food is molded, appearance still matters. And individuals will eat more consistently and in more quantity, often if the food looks better. So it's that attention to detail when we talk about comfort. Everything matters. In this slide, I show a woman offering pleasure feedings or pleasure tastings. It's just drops. She's using a straw to give drops of perhaps, like I said, lemonade or pineapple juice, so that the taste in her mouth is much more pleasant than perhaps just the oral swabs or the lemon glycerin swabs that are used to clean the mouth. I make a special mention of oral care. This can be difficult. However, it's really important to promote comfort. And you don't need a lot of toothpaste. Actually, if the person with dementia resists having oral care provided, it's often because they can no longer spit out the foam from the toothpaste. So it's more important to provide the friction from scrubbing or rubbing with just water. Another option is dipping into pineapple juice. There's enzymes in the pineapple juice that can cut away some of the mucus, and it provides a much more pleasant taste. I want to spend a moment here talking about dementia and pain. Now, you should know that dementia in and of itself, any one of them, do not cause pain. However, a person comes in to a state of dementia often with underlying conditions such as arthritis or diabetic neuropathy, or a person can fall. Please know that a person with dementia can feel painful sensations just like you and me until they take their last breath. And so that's why it's important to pay attention to the nonverbal cues. The person with dementia may no longer able to say, excuse me, on a scale of 0 to 10, my pain is a 9 and I need my Tylenol. That will never happen. What's changed is the ability to even understand the word pain. Quite often I'll ask someone if they're hurting, and the usual reflex answer is no, because they may no longer understand that concept. So that's when I look at nonverbal expressions of pain. The moaning, perhaps the rubbing, the guarding, the grimacing, the not moving. All of those are indicators that pain may be present. So look for those distressed behaviors. And poorly controlled underlying pain can cause an awful lot of distress and agitation in individuals with dementia. And I've actually seen, unfortunately, in many healthcare settings, that persons are no longer receiving their pain medicines because there's this strange myth that people don't feel pain or they'll forget it. So it was really important to work with your healthcare providers that both analgesic or pain medicine and non-drug strategies, meaning repositioning, massaging, heat, or cold, are used in conjunction to allow more comfort. So what are those potential causes of discomfort? Well, if the person has a history of arthritis or spinal stenosis or sciatica, that doesn't go away just because the person has dementia, and that needs to be attended to. Also, full bladder or bowels can cause discomfort. Pressure ulcers or bed sores. Here's one, prolonged sitting. This is one that's often missed. And the individual would be sitting in the same chair or the same wheelchair from morning until night. And I often ask caregivers, think about it. If you sat in the same position, maybe to get up once or twice to be toileted, that would be very uncomfortable. And so you have to anticipate. And it's important then to change positions every 2 hours to avoid stiffening of the joints. And lastly, don't forget to look at the mouth. Look to see if there are any cavities or oral lesions. That's often a missed place for discomfort, and that can also cause a lot of distress. I'm now going to talk to the whole idea of hospitalization in the late and final stages. If you're a family caregiver, you probably know by now that a hospitalization, unfortunately, is not always the most pleasant experience and can be very traumatic for the person with dementia. It's an unfamiliar situation. New people, there's lights, it's busy, it's noisy, it's confusing, it's frightening. And individuals will often be prescribed antipsychotic or sedative medications in order to quiet them, and that can cause additional concerns. There's research that shows that nearly 2/3 of people with advanced dementia are hospitalized in the last 90 days of life. That doesn't always have to be. And some are even admitted to the intensive care unit in the last 30 days of life. This does not have to be. All of this should be funneled through the person's advance directives, their end of life wishes. Expanding the whole idea of comfort means supporting remaining quality of life, especially in the late and final stages. What does that look like? What does it feel like? What does that smell like? What does that taste like? And a lot of it has to do with being surrounded by loved ones and other people who are important in terms of relationships, including perhaps your pets. It's the ability to preserve that person's dignity and story from diagnosis to death. We need others. People with dementia need others to hold on to their story. What has been their life history? What's been their preferences? So if someone, enjoys listening to classical music or perhaps country music, tailor that care, tailor that daily interaction so that some of their preferences are included. I'm showing a screen of an artist named William Udermolen. He was a London-based artist, and he was diagnosed with the Alzheimer's type of dementia when he was about 61. In the left top corner, these are self-portraits. And over 5 years, from about 95 to 2000, one can see the progression of his self-portrait. It was still so vitally important for him to draw and paint. But as we move towards the year 2000, 5 years later, you can see the lack of detail, lack of depth, but he's still there. He still paints himself. William changes. William doesn't completely go away, which is a message I want to implore, that the person you're caring for has changed, but their inner essence will always be there. And William went on to live 7 years later. It's the late and final stages that last the longest in this disease. So, integrate as many sensory experiences to promote comfort that are important to the person with the dementia. So how do they like to be touched? Do they like hand massage? Do they like their hand held? What do they like to look at? Place it around their room. What do they like to listen to? The voice of a loving spouse, special music. What do they like to taste? Now, if you're caring for me, please make sure there's some form of chocolate in the room. what's their favorite aroma? Is it Old Spice or lavender or vanilla and rhythm? People will ask, well, when is it time for hospice care, which is a specialized program for people who we know have about 6 months or less to live. And the criteria for advanced dementia looks like this. The person must need assistance with dressing, feeding, toileting, and dressing. Now, it doesn't mean that they can't help a little bit, but they need assistance. They're incontinent of stool or urine and no real meaningful use of language, though the person can still talk. The person can still walk. And often we wait way too late and don't get the full benefit of the hospice team, which includes the nurses, the physicians, physical therapy if needed, music therapy, massage therapy, volunteers. And then in the last month, the person needs at least one of these different conditions. They may have aspirated food or fluid into the lungs. There may be a bladder or kidney function, or septicemia or blood infection. They could have bed sores, but typically what I see is they're unable to maintain their weight because they can't bring in enough calories from fluid or food. That's when hospice is appropriate. 6 months or less. I have in this picture someone receiving a very gentle foot massage, perhaps with their favorite cream. Again, could be lavender, could be any scent. But what you're doing here is paying attention to the detail of comfort. As we move towards final stages, and the person is moving towards dying, for some, it's a religious experience that is important. So what are those spiritual rituals that have been important based on their faith? Perhaps the person does not want to die alone. So sitting bedside, providing vigils, providing the sacraments. It's providing closure to that life. There are so many different cultural and religious and spiritual ways to provide support. But what's important to that person? And provide it. In the end, after the person dies, some people go on and even provide a ritual to the deathbed. And consider it a sacred space. Here in this picture, we have the American flag draped over the bed for this veteran who died here. And that just can uplift and elevate the experience, particularly for the survivors. So I'm hoping I gave you snippets, at least some insights on what comfort can mean in the late and final stages of dementia. It's more than just the absence of pain. Think of it on the emotional and spiritual and physical level. In all of this, we're learning to care before finding the cure or the cures, because there are many, many different types of dementias. Again, we're learning to care, and a big part of caring is providing comfort. Before I take questions, I just want to offer, if any of you would like a one-to-one consultation, that would be a private consultation. You can reach me at my website, which is Through the Forest. That's www.throughtheforest.com. Or my phone is 773-704-1834 for a consultation. I want to thank the Dementia Society of America for supporting these webcasts. Couldn't do it without you. And please look at Dementia Society of America. It's a wonderful, wonderful organization that provides a whole variety of support to the caregiver. So I'm now going to end the recording so that I can take questions.